I want to thank you today for your patience with regard to our breaks. And as we approach the end of the day, let me say again how glad we are that you could be with us here in North Carolina. Looks like the weather cooperated a little bit with us the last day or two. And I trust you enjoyed the accommodations and the food, and we're thankful that you're here. Dr. Alfred Nickel comes to us today with a presentation which is sure to challenge all of us in an area of local anesthetic, toxicological concerns. As we all know, this is something we use day in and day out as part of our armamentarium in dentistry. And he has a very challenging, to say the least, message to bring to us regarding the use of local anesthetics. Dr. Nichols, an oral and maxillofacial surgeon, lecturer and clinician from California. He has degrees in biochemistry and pharmacology, and again practices oral surgery in the California area, I believe. So listen carefully as he brings this message. Some of you may be aware that issues related to what he will present today appeared in our local newspaper. I'm not exactly sure how that occurred or what the nature of it is, but this is a very important topic, and we trust that you'll enjoy it. Dr. Nickel.
Thank you. Can you hear me? Good. The work I'm about to talk about spans 25 years. One of the questions I have for you, how many members of the American Dental Association are here today? How many members of the ADA are here today? How many, you can put your hands down, how many members use DentaPatch? How many members have read the package insert for DentaPatch that includes a section on cancer? We got one or two, three. And do you realize that in your ADA issue in September that the DentaPatch package insert was published opposite the editorial and lists the carcinogenic studies for lidocaine? How many realize that? We're in trouble, because that's my work.
What issue was it?
Started in September. It's been every issue since September. It's in every office in the United States. First slide. The second thing, this is the first time I've given a lecture where the conclusion of my lecture was published in the newspaper the day before I gave it. And Mr. Clinton, our president, almost upstaged the conclusion of this talk in the newspaper. I build model trains in my spare time, and if I weren't here speaking, I'd be building trains like this one, which was in 2,000 pieces 6 months ago. My education, which spans initially 25 years ago it started, and I became a clinician and a practitioner with a family, and I ignored my education for about 10 years, and I coasted, provided a clinical service in a town. I also taught at the same time at the University of California, San Francisco Medical Center. But my education really stopped. And in 1992, I hit these walls at about 800 miles an hour and was squashed. Because back in those days, I studied microsurgery techniques and developed this unusual apparatus that we could use clinically that integrated fiber optic systems with focal magnification that I could take to any emergency room to provide microsurgical skills to manage and treat patients, including those who might have paresthesia. Paresthesia is a problem in oral surgery where the neurovascular bundle runs adjacent to the root of the impacted wisdom tooth. And I was taught, just like most everybody else, if you take out this wisdom tooth, you're going to have a numb lip and tongue. and that is a result of you, the surgeon, taking the tooth out. Well, I was proven wrong by my own studies. Another x-ray showing a periapical with the neurovascular bundle adjacent to the root of the tooth. Both these teeth were removed without any injury to the neurovascular bundle. What this precipitated was in 1981, I was challenged in a courtroom in Martinez, California with an associate who was working with me over a lady who had every nerve in her mouth numb after having teeth out like those in the prior radiographs. And so in 1987, after that trial, Dr. Charles Alling in Alabama, the late Dr. Alling, challenged me and said, can you prove anything about what you're saying, that paresthesia or persistent numbness is associated with local anesthetics and not the surgery, as you have written in a letter to the Journal of Oral Surgery. So I read through about 4,000 charts. Took me 3 months. I could stand it for about 4 hours. And I went back and looked at all those charts because I knew something, that in our practice we had dropped lidocaine at a certain time frame and had introduced carbocaine, the trade name carbocaine or mepivacaine, in our clinical practice of removal of wisdom teeth. We knew that date. So I decided, well, I would take 2.5 years on either side of that and look at every chart and tabulate them. And it turned out I had made notes in the chart where we saw no nerve, and the nerve was seen during the surgery, and yet these people had paresthesia. I knew certain properties from my lectures in local anesthesia, and I knew that one of the things that kept pushing me was that the different sensory functions of the nerves were related to fiber size. I also knew that the differential sensitivity of our local anesthetics also related to those fiber size. In other words, if somebody had lost the feeling of touch but could feel pressure, then the nerve wasn't cut. And here's the data. It's in a badly published or badly written published article in Anesthesia Progress in 1990, but the data is significant. And here were the few people in this study out of, I think, 3,400 or 3,500 cases, about 52 cases had paresthesia, that the difference with the use of mepivacaine versus the use of lidocaine was statistically significant, and that the appearance of these clinical conditions of numbness or paresthesia was associated with the drug and not the surgery. I assumed going into writing this article that paresthesia was due to surgery. But the data said that the people who had paresthesia, that the doubling up from the incidence of lidocaine, the doubling of the number of people was statistically significant, that their paresthesias were associated with the use of lidocaine or mepivacaine, and nothing to do with me as a surgeon.
You said previously that
If they could feel touch, but not, no, pardon me, if touch was deficient, pinprick or brushing of the lip or chin, but they could feel pressure, then you had a nerve that was continuous. By definition, paresthesia is limited to the sensory feeling of touch. Can we limit the questions and at the question and answer period? I'll come together. So when we looked at all the data in the office, it turned out that indeed 98% of these cases reverted back to normal if I did nothing as a surgeon and did no microsurgery. So all that stuff I learned about microsurgery was useless. Oh, we're going backwards. So being a biochemist of nature, I had to create a model. And this was published in the article. And this is the model that I published, that if our local anesthetics, ester or amides, involve themselves with a sensory nerve, most of the time we get dental anesthesia and loss of numbness. But a few of these people will get numb, and possibly through a process of hydrolysis, an alcohol would remain on the site. And that, to me as a surgeon, could explain paresthesia chemically. Today I know that hydrolysis of either one of our ester or amide local anesthetic groupings will result, the paresthesia can also result from the other metabolite, which is aniline. And aniline is the only group of compounds that are well documented since 1896 as human carcinogens. This is what I lectured about and published in the article. This is chemistry, talking about the chemistry. Here's like, for instance, procaine being hydrolyzed into two components. Please note that procaine has this amino group on its benzene. And I just thought, well, this is how an enzyme works, so this is how it's going to go. And these products, these alcohol products, could explain paresthesia. And if you notice with the amide groups like lidocaine and mepivacaine, see what's missing here? The chemical structure known as aniline. But a light bulb went on. And the light bulb was that here at UCSF back in 1970-71, I was doing my graduate work in pharmacology, and I was interested in the molecular basis of anesthesia. And being a dental student and doing graduate work concurrently, I spent my time in one of these windowed areas around the clock over a goofy machine that could produce some data that, to me, was just a biochemical probe. And in those days, I took 36 brains, cow brains, and ended up with, through a purification process, can we focus? I'll need help back there. And we would end up with about 500 milligrams of a protein material from these 36 brains that would be subjected to essentially an optical process like a spectrophotometer, and we'd take a reading of what happened to that protein in that solution. And this is called circular dichroism, and it would produce these nice curves. And I decided to study one of the signals, which is for an alpha helical area for these proteins, that they seem to have a lot of helix. And can we focus? This data would be plotted, and this would be the change in the ellipticity of the light as it passed through the solution. And being a biochemist, I said, well, I'm going to denature this thing, and I'm going to use temperature as a probe of this protein. And so I would change the temperature of the protein. Our protein in purification was done at nearly 0 degrees centigrade. And the circular dichroism of these proteins, bizarrely, would sort of go through one phase, that was a level phase, and then they would sort of increase, as we increase the temperature, they would change their conformation, and their helical conformation would change. And this was measurable. At the same time, I measured the enzyme activity because this happened to be a protein that had cholinesterase activity. And at the time, in 1971, people said the enzyme could not be associated with the sodium channel. But me being a dentist, being a little bit nuts maybe, ran down and grabbed a bottle of lidocaine and stuck it in that solution. And the lidocaine did something. The lidocaine maintained the conformation of the helical structure of that protein at this plateau and wouldn't release it until a much higher temperature, telling me that the lidocaine had behaved in a receptor-like fashion. The receptor-like fashion that you do when you inject every day a carpiol lidocaine in a patient and numb their nerve. Today, what you're looking at because I realized from the clinical picture of paresthesia that this was the same chemistry. Today, there is now a United States patent issued against this drawing. It's the second patent. It was issued in December of last year. This patent initially started the writing of the patent in 1991. The patent office, my wife and I wrote this patent. Well, I wrote it and she typed it. And we submitted it on our own. And the patent office came back and said, this is highly patentable and you must get a patent attorney. In other words, I filed my patent application without a patent attorney. And ever since then, my life has been scrambled. Because I also recognized that there was a zone of anesthesia in this transition curve, and then there was a zone of product production. In other words, this enzyme started chopping things up. And what you got in this second zone determined what is now in another patent of new local anesthetics that are aniline or carcinogenic free. The theory behind it was that the ion channel consisted of a helix that through heat transformation would allow an uncoiling. This uncoiling would open the sodium channel pore and you would have nerve conduction. If you stuck in something like lidocaine, this event would be prevented and you would prevent nerve conduction. Now this is on a biochemical level. This is not on a biological level. This is a protein in a solution. The next step below this is the atom level. And this is the actual data in which down here you had the receptor protein, cholinergic protein in solution, and then when you added lidocaine, the percent of loss of helix was reduced, and then you got it back as you increased in that zone of that drawing I showed you. This happens to be now, in retrospective, the actual data of the discovery of what is the molecular basis of anesthesia. This data right here. This is the structure we're looking at. It's in the synaptic area of a neuron. People call them receptors. I call them ion channels. This is a calcium ion channel. We have sodium ones. We have glucose channels. But this structure consists of a group of protein subunits that comprise a helical tube. And that's the gate from inside and outside the cell that receives messages and tells the cell what to do, send the message on or not through chemical mediation through the synapse. The structure I had in the test tube, and this is I believe this is 1990. This is a computer model of the helices. These blue structures are the helices surrounding the pore or the gate of an ion channel in cross-section. The tube has been taken and cut in half. This is another model done by Dr. Guy, computer guy at NIH. Dr. Guy used computers to show that there was a helical structure and that when the helical structure opened, the gate would open and close. The data I ran into in the laboratory in 1971 is the data of how this structure works. This was published in an article on regional anesthesia that I wrote and presented in Tokyo, Japan at the New York Academy of Science, showing that the helix on our membranes, our neuron membranes, consist of these helical structures that open and close. This would give you impulse and ion flow through the membrane. Our local anesthetics come along, they get stuck in there, we get anesthesia, they break loose, over here, and disassociate to return to normal. But then every so often somebody gets the outside of their channel, chops it up, and they get the alcohol stuck in there, and they get numb and they get paresthesia. And 98% of those with paresthesia would go back to normal if I did nothing as a surgeon. Now, why I wanted to show you the prior slide is that the prior slide shows you a structure like this, representing the cholinergic ion channel receptor. This is from Dr. Shengzhu at Pasteur Institute, and it turns out this is the X-ray crystallography redrawn, but this is actually how it looks through X-ray crystallography. The ion channel looks sort of like a tube with, I believe, 5 subunits. Each subunit is an alpha helical in structure. There are 2 cholinergic enzyme sites located on the outside of the ion channel, and there, I believe it's around 300 DK, molecular weight of 300, and it turned out the molecular weight of the structure I had in my test tube was 300. In other words, the X-ray crystallography turns out very similar to the model concept that I devised from chemistry paresthesia and published independently without seeing the X-ray crystallography. This created a lot of commotion in Tokyo, this picture. So using that, the goal is, well, if paresthesia is from your local anesthetic, can you get rid of it? Now you're putting science into action in your office. And the answer was yes. We promptly eliminated the block anesthesia technique. We reduced the amount of local anesthetic. We used infiltration only. We took out all those bad teeth that you could never take out, and they didn't get numb. And our reduction in paresthesia monthly dropped almost 90%. But that too was published. That was published in the chapter on regional anesthesia in 1993, I believe. So my interest has been anesthesia, and I continued with that interest of anesthesia. This book was owned by a doctor who was the best friend of Horace Wells. Can we focus that? And this medical doctor, this is a picture of Horace Wells, who discovered nitrous oxide anesthesia. And the night he discovered, can you focus that? You might have to dim the lights. And the night before he had his tooth pulled under nitrous oxide and the discovery of anesthesia for clinical use, Samuel Cooley was breathing the laughing gas on the podium, and he was the gentleman who got off the podium and walked down the aisle and gashed his leg. And Horace Wells said, "Oh my, I bet you can go to sleep and you won't feel a tooth coming out." Well, in that little book on anesthesia that I purchased in San Francisco in my interest of anesthesia was a slip of paper that the man who sold me the book insisted I buy the book because he said, "You got to have this piece of paper." I didn't know much about Samuel Cooley, but what's interesting is this is a piece of paper that Harvard School of Medicine believes was written about 1856 by the same Sam Cooley who gashed his leg that night. They've checked it against his hand. It is the hand of Samuel Cooley. We know it's about 1856 because when the discovery of anesthesia in 1844 occurred, he was not colonel. He became a colonel in the 1850s. And you can read that, but he felt he was the discoverer of anesthesia and argues so in this document. And this document would have gone to Congress in 1875 when there was a discussion on who to recognize as the discoverer of anesthesia, but it was torn out of the documentation and remained in that brown book for close to almost 100 years. That sits in a file at my house with this book, and if you focus this is the page out of my lab book the day that I discovered what I thought was the molecular basis of anesthesia, and it says quite clearly that this ion channel, or what I called it back then was a transducerase, would permit action potential transfer and also would be the basis of anesthesia if blocked. And that's the actual notations. Now, my first clinical article that I published outside of the field of pharmacology and biochemistry was about cancer. And I thought cancer was totally unrelated to anything I ever did. And obviously, here's a carcinoma of the floor of the mouth. And this was around 1992 when I started to realize that we were dealing with cancer because of the other metabolite of our local anesthetics, which was a carcinogen. This was where I went to present my work in Tokyo. And, pardon me, these are the posters. There are 4 of them. And I had to take a picture because all you folks don't go to Tokyo. And this was the first time that the New York Academy of Science had had an international meeting outside the United States. And this, they told me when I was there in Tokyo, was the first time that a dentist in 175 years had 4 papers peer-reviewed, accepted for presentation at the Academy. There's 1, 2, 3, 4. This is science. That this ion channel work is real science. And this science, if it had the support of dentistry, could go a lot farther than what the rest of this lecture is going to talk about. This is science of how your nerves work. This is science how anesthetics work, how pharmaceuticals work, how the foods you eat work, because the critical point of where they work are these ion channel structures. To this day, there's no money to fund any of this work. I want to show you how I write science so that you know they're not all pretty slides. But this date is the 10th of a month in 1989. And I sat down at the kitchen table, and this is how I write things. And this is the metabolism of our local anesthetics. And I started listing my observations of how these were all related to my thesis work. Here's the production of the alcohol. Again, I still wasn't focused on the aminobenzene compound. Now, during this time, because of my excitement about the molecular basis of anesthesia and neurotransmission, I had been writing letters to the late Dr. Linus Pauling. And one of the letters he responded to me about was that he empirically had avoided local anesthetics in the dental office. And he intuitively didn't want his dentist to give him a local anesthetic, and to the point that they would argue about it. And this was in 1990 he wrote this letter, and I sat there and I said, what would a chemist, you know, we've been talking about all this big biochemistry, these ion channels, the receptors, and alpha helices, So what would a chemist want to avoid some dinky little compound about his whole life? So I sat down and rewrote that slide I showed you earlier. Only this time, I picked up something. That one of the first metabolites of our aniline-based local anesthetics would be an aminobenzene compound, in addition to the alcohol. And this aminobenzene compound, I knew from basic chemistry, was a problem. This is called a reactive compound. This is a killer compound. This is a compound that destroys your DNA. And it can do it in a delayed fashion. You can have it today, and it won't hit you until 5 years from now. So I sat down, if you focus this, in May of 1992, and I wrote what was on that sheet of paper that I wrote at the kitchen table, listed all my concerns, and I had come to the conclusion that the ion channel structure had something to do and play in the role of carcinogenesis initiation, the beginning of cancer on a cellular level. So I listed all that and wrote Dr. Broder at National Cancer Institute. And Dr. Sam Broder was the director at the time. And he had a fellow there named Dr. Robert Guy, who did those computer models on ion channels, write me back a nice letter. And this letter came back to me, and the part that set me off my feet was... Focus? Yeah, could you focus? I don't have control on focus. The thing that that really surprised me was that he said it was reasonable that some cancers could be associated with my concerns about ion channels. And at that point, my life changed. Because now, all of a sudden, where I had been studying paresthesia, I was now studying cancer. Because in a matter of 24 hours after receiving Sam's letter, I realized that that the package insert for the local anesthetic prilocaine had carcinogenic studies in it for animals. And its metabolite, which is orthotoluidine, I pronounce it wrong, but it's orthotoluidine or toluidine, which is an aniline compound, is highly carcinogenic in animals. And that's in the package insert in your office. And you're injecting this in kids. And you've never been told what the margin of safety is with that compound. Because I'll tell you right now, 80 or 90% of that metabolite is going to be a result of that drug being put in the tissues. And you don't even know what the margin of safety is. But suddenly I had a model about ion channel toxic mechanisms that would lead to an exposure of a carcinogenic metabolite called aniline. And so here's your model. Here you start out with your local anesthetic or substrate. Here's your ion channel that functions on the basis of thermal changes. And in this case, it was acetylcholinesterase. Through hydrolysis, would drive on to end up what I thought was a free radical oxygen, but you can put in the aniline structure here, and then there is the alcohol of paresthesia. Oh, I keep going backwards. I apologize. So, to look at our local anesthetics, a friend of mine wrote these up, and he felt, if you notice the amino groups missing up here on procaine, but there should be an amino group here. If you go and look these up in your ADA handbook, they'll tell you they all hydrolyze here between the carbon and the benzene ring, or between the nitrogen and the benzene ring, and the nitrogen and the benzene ring. But that's not how an enzyme works. An enzyme is very specific to a chemical arrangement. And I knew as a biochemist that hydrolysis would be occurring on the other side, so that the amino groups in all cases, and there would be a nitrogen here, if you hydrolyze there, it would be carboxylated aminobenzene compound, that you'd have aminobenzene in every single one of our local anesthetics. Well, you don't think that's a nightmare, because I'm looking at cancer. And I'm looking at animal studies that are for real. And by this time, I contacted FDA, and FDA on, for instance, the Citinus local anesthetic had done, I believe, 4 serial studies, each 2 years long, in rats and mice, and they were all positive for carcinogenesis. And when we received the microfishes at my office, I ran down to the pharmacy and stuck them under the reader, and much to my surprise, here is an article saying that the metabolite of Citinus produces breast cancer in female rats, 99.99% positive. Well, what's that going to do to your wife or your girlfriend or your mother? You want a nightmare? This was a nightmare. Could you focus? So I started tabulating data. And here are the metabolites of our local anesthetic. These are the aniline metabolites. You can call them aniline homologs. There are a whole bunch of names for these structures. Some people call them xylidine, orthotoluidine. This is xylidine, this is orthotoluidine, toluidine, this is hydroxyaniline. These are all known animal carcinogens. This is a well-known human carcinogen since 1896. This is your source of bladder cancer, and each one of these, the body biochemistry will demethylate to this compound. So if you stick this in, you're going to be there at some time in that person's metabolism. The other thing I want you to know is we tabulated out what the percent of hydrolysis is theoretically and based on manufacturers. The manufacturers constantly downplayed the percentage of hydrolysis, like 40% on sitness. Well, the FDA said, let's go find out what lidocaine's all about. So it turned out there was an animal study on lidocaine in rats, and it was published. It was done by the federal government, and it too, its metabolite was, this 2,6-dimethylamine was highly carcinogenic in that rat. But the people who did the study thought it didn't relate to dentistry or medicine, had no bearing whatsoever. And so FDA went and they did what's called the human liver slice study out of this type of data. We were jumping all over them. And the human liver metabolism, these are human slices of liver that they subject to lidocaine, it approaches over 80% conversion to these metabolite structures. So where I saw in my thesis, I had data to say it was 93%. FDA early on said it was 73%, but I now have received the article, which actually was published last year, and it is greater than 80% in human liver slice studies. And that was just published by Dr. Parker, who did the FDA studies. At this time, science was no longer science in a laboratory. It was in my office, it was going nutso. The phone calls to Washington, D.C. Ran 2 to 3, sometimes 4 a day, for me to them and them to me. And at one point, the advisory committee was meeting for the FDA on anesthesia and life support. We triggered those meetings. And the second meeting was when the human liver slice data was presented, and in which case your friendly pharmaceutical company was there, but I could not be there because I don't have money or resources. And at that meeting, the actual data on the human liver slice studies was presented at greater than 67% conversion of lidocaine to the carcinogen. And our local anesthetic manufacturer, when I talked to him on the phone 3 days later, said, oh, no data was presented, nothing. Absolutely nothing was presented. And I thought something was wrong because they said they were going to present that day, and it included a letter that they had asked me to write about the field of anesthesia in the United States that was presented in the meeting in my absence by the FDA. And a copy of that is available in our office. We have a package of information, and if you want to get that, you can. The flyers that you have here today tell you how to obtain that. And so I sort of blew a cork, because I thought somebody was lying to me. Our local anesthetic manufacturer, I felt, was lying. I couldn't believe that nothing had been presented when I was told it was going to be presented. So I contacted the Commerce Committee, Congressman Dingell, directly his office. Well, at that point in time, I also had calls to National Toxicology Program, and the director himself was on the phone in that week to me to say that they were going to provide me with the actual transcript of the meeting, which showed that lidocaine was, in human tissues, converted to a carcinogen. Of course, Congressman Dingell's office was going ballistic at this point, and his secretary ended up calling us weekly. So here I am doing oral surgery, pulling teeth, and on the other hand, I have a congressional office calling me to find out what's new and what are you doing. As if I could change the world overnight. The other thing I want you to be aware of is that the IARC, International Agency for Research in Cancer, accepts 2 to 10 microgram of aniline per cubic milliliter to exposure to skin industrially. That was the other group I was talking to was OSHA, and OSHA was petrified because the dentists were dealing with a factor of these aniline compounds anywhere from 10 to the 4th to 10 to the 6th greater than anything used industrially. for exposure for a human. Well, out of those anesthetic life support committee meetings came a package insert for what's called EMLA cream. EMLA cream consists of prilocaine and lidocaine, and it turns out there's a fluke in the law that the federal government can only change package inserts for new products. That's why the lidocaine in your office does not have this carcinogenic labeling. But EMLA cream was the first, and Denapatch was the second. And this is sitting in every pharmacy in the United States, and it tells you that just for the cream on the skin, they don't know what the margin of safety is, and you're injecting it. And here are the carcinogenic studies for lidocaine and citinest, or prilocaine, both listed in that package insert. So the professions have been notified. We have met with the Commerce Committee. We went back and met in Washington, my wife and I, after a week. We met with the Commerce Committee. We went all over Washington and visited with all sorts of people. And we were bluntly told that this is all the FDA has to do, is change the packaging insert, put it in your office, and you're notified. Now the mess is on your back. The monkey's on your back. The thing about this was, does this relate to humans? Well, the animal studies were positive, if you focus, for breast cancer. And those little rats and mice got it very nicely. And so if humans got it, then let's look at the human data for breast cancer. Well, it turns out breast cancer human data is the best tracked in the world. It's the best data. The women have done their job. So here we are in the United States, and breast cancer started to appear. These are supposed to be years down here, but somewhere around in the mid-1980s is when we started to peak our breast cancer, and if you read the paper yesterday, it's now plateaued. Well, being the acquisitive person I am, I like the telephone. I called up the Imperial Cancer Research Fund in England one morning and talked to a lady there, and I said, why I was calling was I was interested in knowing if their breast cancer rate rose and plateaued 11 or 12 years before us in the United States, because I knew that in 1948 was when lidocaine was forcibly introduced in England, and in the late 50s, 60s is when it came into the United States. The calling card of aniline in a population is the cancer rates show up 20 to 25 years after the aniline has been placed in that population. So you have a delayed appearance before it appears in a population. I called her from home and said, was in the early 70s, was that when you peaked? And by the time I arrived at the office, 30 minutes later, she was back on the phone from England and said, Dr. Nickel, can I fax you the raw data? Because what you just told me on the phone was very accurate. So I looked a little harder, and then I made phone calls to Connecticut and the Connecticut Tumor Registry, if you will focus that. And they have, through Barry Miller at National Cancer Institute, they have logarithmic plots of breast cancer in Connecticut. And they have actual data going back to around 1942. And then if you notice, the lines suddenly break and change and the rate changes. It turns out the date of inflection of these two lines is about the date when lidocaine was introduced in Connecticut in the 60s, early 60s. And of course, the 2,6-dimethyl-aniline is meaner than the hydroxyaniline. This is known at OSHA. So the hydroxyaniline of Novocaine, which this data represents, had a nice line, and then when you trace this whole thing out and went to zero, this is a log. This is a log plotting. If you carried this line out to zero, it turns out zero hits 1905, 1910, theoretically. This is for breast cancer in Connecticut. Well, I understand Dr. Kessler, if you focus. Dr. Kessler, this is not Dr. Kessler, but Dr. Kessler was having nightmares I was told at National Cancer Institute folks that the FDA, that Dr. Kessler could not even sleep at night over my phone calls because we didn't have an alternative. Could you set up the overhead? Because we're going to need that. And I was in the same boat. I didn't have an alternative. All I could do is use Marcaine, which was the least amount of the aniline metabolite, use it sparingly, use my general anesthesia that I'd been taught by and had been taught in Southern California, but was developed by this man, Dr. Adrian Hubble. And Dr. Hubble was a pioneer in clinical anesthesia in California. And Adrian Hubble was an oral surgeon in Long Beach and had an interest in anesthesia and chose to explore different drugs for clinical use. And in 1930 and 1940, and I've talked to Adrian, he's 96, he's a Mayo graduate. Adrian Hubble, brilliant as he was, chose drugs on the basis of animal studies, and he chose two drugs, the barbiturates and the narcotic Demerol, because they did not produce tumors in animal studies, and he chose those as a basis of clinical anesthesia that he used and developed in Long Beach, California, which became outpatient general anesthesia for the oral surgeon. He never used local. Dr. Hubble added another caveat, was that he started this in 1950, and it spread throughout the oral surgeons in Southern California. And I, as a person who looks at numbers, said, well, could it be that Dr. Hubble's anesthesia, that there's something different in Southern California than Northern California, because the Northern California oral surgeons where I practice don't like the Hubble technique, even though I have the Hubble technique at my disposal and am trained with it and have been using it, except I've been using it with local for about over 20 years. So I looked at the data. We actually pulled the cancer data, and guess what? If you drew a line straight across California at the point of where the oral surgery societies changed, that south of that line had a lower cancer mortality rate, and north of that line had a cancer mortality rate exactly the number predicted for the practicing oral surgeons north of that line, -5. Well, Adrian Hubble's work, of course, became a focus in our practice because all of a sudden I had stumbled into a clinical technique that was cancer-free, and I could do oral surgery with it. And I could do it tomorrow. I didn't have to get trained. I could do tomorrow. And I did. And one of our patients woke up in anesthesia, and she was in pain. A 16-year-old girl had 4 wisdom teeth out, impacted wisdom teeth, and she woke up and she was in pain. And the Demerol IV and the barbiturate, of course, had worn off the barbiturate. She was awake. I couldn't control the pain, and she was sobbing. And I thought to myself, well, you remember the Nicental story where the children's dentist would inject it adjacent to the teeth and sedate the patient? So I said, why don't you give me some of the Demerol and I'll inject it next to this girl's tooth where she's in pain. And the site, number 17, the lower left wisdom tooth. And within 40 seconds, that girl said to me she was free of pain. And I only put in about 10 milligrams. That night I went home. And indeed, I looked at Demerol. And guess what? Demerol has the structure of procaine minus the carcinogen. Here it is. Here's Demerol. It cannot produce an aniline metabolite. It can be hydrolyzed by the enzyme of hydrolysis of the ion channel. And here's the alcohol of a Novocaine chain. But it can't make the aniline. Well, that was a year ago. We now use Demerol in low doses, injectable as a replacement local anesthetic. It works about 60% of the time, 70% of the time effectively in surgery. If it doesn't work on the first go around, then we'll boost it with a little bit of Marcaine. And I'll tell you, today we sometimes will take out a tooth with 1 drop of Marcaine, literally 1 drop of fluid, or none. They don't feel anything. The tooth's removed. I've done the surgery, and I've done the toughest surgeries, including those with the nerve close to the bone, the nerve close to the root and whatever. I've been able to do it. I haven't killed anybody. I'm a year down the way. And indeed, in medicine, they have been using this for a bunch of years as a local anesthetic. It is the only narcotic that has a local anesthetic activity. Now, the other thing that I did approximately 3 years ago was I realized that you folks need a replacement in that carb peel. And so I embarked to change a local anesthetic. And to do that, you must have a patent. I discovered pretty quickly on you had to have the legal right to change this. You could have all the science in the world. If you're causing cancer in your office and you can't do a blooming thing about it unless you have the legal right to change it. And then the second thing is I didn't have a laboratory. I don't have it. I know the chemistry. I know what I want to get. I know where I want to go, but I didn't have the facilities. But I've been working with the federal government, and in our trip to Washington, D.C., we carried a grant proposal to the United States Army that was based on a patent application for new local anesthetics that theoretically should be local anesthetics based on everything I knew, and also would produce a metabolite that couldn't cause cancer. What I do know at this point in time about that patent application, it is a patent. It is a patent that's accepted in the United States in addition to 96 other countries. This is the first patent application that anybody has ever seen that did not, that is in 96 countries. Up to this time, under the patent treaties, the United States has only had allowance in 28 countries. So I think somebody has spent some big bucks, because that's what treaties are about, to add another 70 countries onto this patent. I do believe that out of the 6 drugs I designed, that there are probably 4 or 5 that are clinically useful. What do I think is going on? A study was just finished in the United States and England in 21 institutions on local anesthetics. All solutions were double-blind. Nobody knew what they were, and everybody says that it's going to be ultracaine from Canada. And ultracaine is a local anesthetic that does not produce a carcinogen. And my patent application is like ultracaine, but it is modified in the ring structure, because I recognize that one of the components of the ultracaine ring structure might produce some problems clinically in terms of disease. Well, at any rate, I can tell you that for FDA approval of a single drug, you need 4 or 5 institutional studies. The studies were finished in November, late November, in 21 institutions. I don't think it's ultracaine, because the gentleman from USC came up to lecture us the week after they submitted their data and told me how the drug worked. And the patients love this drug. Works in a minute. Duration is 3 hours. They have no side effects. And by the way, these aniline compounds are cardiotoxic. They cause lots of problems. They don't have any cardiotoxicity. These people love this drug. So I quickly got on the phone the next day and called Washington to my other friend at University of Washington, and I said, could your patients tell you what the drug was like? He said, no, they couldn't tell anything. I said, well, I've used ultracaine, and I have. It's not FDA approved in the United States, but I've used it. We smuggled it in so I could use it. And I'll tell you right now, there's not a person in this room who could tell me they've had ultracaine. You can't compare it from lidocaine. So USC had a drug that was different than all the rest. Well, one of the drugs in my patent should be a bullet. It should work just as USC described. So now, if we turn on the overhead, do we have a grease pencil? You get the conclusion of my speech. The conclusion of my speech, obviously, is that the metabolites of our local anesthetics cause cancer. And in animal studies, they produce all cancers that any of us know about. And the only type of human data you can compare with is mortality data. It's the only data accepted worldwide by IARC and the World Health Organization as comparable data. So I can compare data in Walnut Creek, I can compare it in North Carolina, I can compare it in wherever town you come from or whichever country you're from. I can compare France, and I can compare Germany, I can compare England. And that number, I can go anywhere and say, well, what's going on with the trends? So to prepare for this lecture, is there a plastic sheet, a transparency that I can write on? Below my hand? Okay, see it. So 8 days ago, I started looking at some data in the United States. And the number one, you can see this, number one in cancer mortality in our country is the District of Columbia per 100,000 people. So there are two time frames that we have. We have a 1984 to 1989 data period, that's 5 years, and we have a 1990 to 95 data period. We have two data periods to look at. So I went and ranked all the states because everything is published alphabetically, so I ranked them who's number one, who's number two, number three, and then I noticed something, that some places had fallen. Their cancer mortality had fallen in the period, the second period. And so, you see, I have fax lines to the White House, have had since 1990, the beginning of 94. When I wrote President Clinton, I said, we got a problem, big time, and it's these aniline things and our metabolites of our local anesthetics going to kill us if we don't do something about it. The Clinton healthcare package, I can tell you why it died in the United States, because I played a role in it. What happened was, I realized that if we went to nationalized health care, everybody in the United States would get local, nobody would get general anesthesia. The cost-effective way, only way to provide nationalized health care is with local anesthesia. And if we did that, we'd all get cancer. We'd all be dead. Or have a cardiac arrest, or a suicide. So, I ranked them. This is what I sent to President Clinton 8 days ago. The number one area to fall in the United States was District of Columbia. The number two area that fell in the United States was Connecticut. The number three, these are deaths. The death rate is falling. Number three was California. Number four was Maryland. Number five, Rhode Island and New York. There's another 10 or so that's, you might say fell, but they didn't fall enough to be statistically significant. And the rest of the states remained the same, or the other 28 went up, including this state, North Carolina. Well, guess what? Your newspaper says that National Cancer Institute, this is a newspaper yesterday that they published here, there's a fall in the decline of cancer deaths. And guess what? It's based on 5 states and 4 cities. Okay. Well, in 1992, I was making phone calls 2 to 3 times a day to that place in D.C. I was talking to the Connecticut Tumor Registry in Connecticut. And in my practice, I didn't have flyers like what you have on your table today that explains what causes cancer, in my opinion. But I told patients, and I lost my practice because of that. Because you folks, the general dentist, would not support me if I told your patient what caused cancer. But when your patient came to me and I treated him, I'd have to tell him about my research, which meant that the local anesthetics I would use might possibly cause cancer in them. And I told him about it, verbally. And yes, I lost my practice. But I told the patients. And you know what the patients did? They went out and told their friends. because the cancer mortality in California has fallen. In the time frame I spoke out, which I spoke out from 1992, 93, 94, 95, and then Maryland fell. Well, that's the headquarters of National Cancer Institute, and one more thing. Maryland is the bedroom community to Washington, D.C. So the secretaries who I had to talk to carried it home, and they talked about it. And Rhode Island's next to California, and of course, New York happens to be where the guy in charge of the Anesthetic and Life Support Committee teaches, and of course, a lot of my friends in oral surgery happen to be there, and I talked to them. And it got on the street, is what I'm trying to tell you. Without a flyer, without a news release, it's on the street. And it's the front page of your paper. Cancer rates are falling. The other thing I did was about March of '96, I faxed every dental society in the United States the sheets that are sitting on your tables. And you have to realize the folks here, the professionals, are not in your dental society offices, so those secretaries have it. So we have forwarded that information on to National Cancer Institute and American Cancer Society and said, are we going to see another fall when the next data comes out next year? Are we going to see less people dying of cancer? In other words, what I'm trying to say, you can stop cancer just by talking. We professionally have an obligation to stop cancer in our office by changing the drugs we have. We have a choice of drugs now. We have a choice that we didn't have when I started out. What motivated me to find the Demerol was I had a young girl that only got 12 milligrams of Marquine, not Bupivacaine, 12 milligrams of Marquine for her wisdom teeth, to have her wisdom teeth out. And I thought that was low because I was taught to give somebody 150 to 180 milligrams of aniline to take out their wisdom teeth. That's what you were taught. So I gave her 12, so that's a lot less. Well, this 19-year-old girl within 6 weeks came down with Hodgkin's lymphoma. That's what motivated me to find the Demerol. If you think there's nothing to what I'm saying about the cause of human cancer here, that's fine. You're entitled to your opinion. But I challenge you to interpret the data as I have. I've looked at the data. I've used it. I've used the data to find substitutes for you to use in your office. I've used the data to talk to people in Washington. And I've used the science to develop an alternative that I hope Washington has done the homework. I hope that those clinical studies have been done on new local anesthetics that will be available to you. That's what I'm hoping for. So that's where I stand today. I'm sort of an outsider in the Washington track, so I don't get told what really is going on. I can guess. But I keep pumping information into them, and as I say, President Clinton almost upstaged my talk by giving you my conclusion. In other words, cancer in certain places in the United States is on the downside and predictably on the downside. Thank you.
Thank you so much for that challenging presentation. What we're going to do at this time... Can't hear me, Mike? There we go. What I'd like to do, Dr. Nickel, if you'll remain down toward the front, all of the presenters, we'd like for you to come forward at this time. We're going to have a question and answer session. The way we're going to handle this, there'll be, I believe, a free mic available that we'd like you to get on the mic when you ask your questions. The exhibitors at this time, you're more than welcome to go ahead and begin to break down. Looks like most of you have done so. Just leave the tables in their place. The crew here will take care of those things. Just before we start, I'd like to have Charlie Brown come forward. Is he here with us? He has some important information to pass on to us from Consumers for Dental Choice and their activity with the state boards in the various jurisdictions. Charlie?
Good afternoon, and it's real good to appear before you all again. In your program, right in the front, under your first tab of your notebook, is a report of our 50-state petition project, Consumers for Dental Choice, and the work that my partner Jim Turner and our associate Jaylene Saraceno and I are doing in very close cooperation with the good people from DAMS who are the consumers who are going to these boards, Leo Cashman in Minnesota and Sue Ann Taylor in Georgia and Renee and Bobby in Iowa and people in Lois Schnapp in Louisiana and so on. And to Bernice and Teresa, Bernice Rudlick and Teresa Kaiser, it's just great what you've been organizing. We've been before a lot of the states now. We've gotten a lot of responses. And what we have here is a cover letter that if you want to get the actual correspondence from your state, if any, now about 19 states haven't even responded at all, except with anything at all substantive, but many states have responded, and we're happy to do it. There is a summary memorandum here. What is exciting is that many of the states are now responding with an indication right in writing that there is going to be a level playing field in their state, that there is going to be a fairness, there's going to be mercury-free dentistry in their state, and they're laying it right out. Wisconsin is a very exciting one, and one you may want to cite in your state. I would like to read from it here because it's just capsulizes what we asked for. The board, this is the chairman of the board of the Wisconsin Dental Board. The board may not use its disciplinary authority in a manner that inappropriately stifles appropriate and innovative treatment modalities in dentistry, right? Or which would serve to suggest there is always one and only one school of thought to which a dentist must adhere in order to be found competent to practice the dental profession. Reasonable, and this is not me, this is the Wisconsin Dental Board. Reasonable and competent dentists may and often do disagree on a patient's treatment modalities. With this in mind, the board starts from the premise that a dentist must have a reasonable professional basis upon which to recommend or provide patient services. The fact that there are different legitimate schools of thought regarding proper treatment, each based on reasonable and articulable factors, does not lead to the conclusion that the members of one school are competent and the others are not. That's the message that we're hoping to take board by board. The Kansas board has said, the lawyer for the Kansas board, the Attorney General's office, said there's nothing in the Kansas rules that would prevent a dentist from discussing the pros and cons of amalgam treatment with his or her patient. The New York board, a little vague but helpful, says they don't regulate the type of fillings that go in someone's mouth. You can use that some in New York. In California, they made it clear it's the patient's choice. In Wyoming, we really got an opinion dealing directly with the American Dental Association because the Wyoming Attorney General said even though the Wyoming board has incorporated the board of the ADA Code of Ethics into their rules, the advisory opinion, that hostile to amalgam advisory opinion, will not stand and will not be enforced because that's not part of the Code of Ethics. It's merely an advisory opinion. So, it's exciting. We're seeing a lot of really good developments, and I think we've done it in part, certainly with a lot of consumer help. I think we've taken the right strategy this year with our 50-state petition, and I think there are three ways we did that. One is we defined the issues. We stopped letting the other side define the issues about amalgam removal. We defined the issue, access to mercury-free dentistry, the consumer's right to get access to the dental care that they want, which might be mercury-free dentistry. The right of a dentist to practice mercury-free. Who can argue with that? That a dentist wants to be mercury-free, he or she can be mercury-free. That we want a level playing field for those dentists. I mean, that's the message that we've tried. Simple, one that's pretty close to unassailable. Certainly a lot of boards are trying to assail it in some way, but it's a message that we think is reverberated back with a lot of good statements, and you can go through, look for your state and see that. I am going to send all the letters to a couple of people, to Bernice Rudlick, so she has all the letters, to Mike Ziff, to your officers, Jess Clifford and Walter and Ronnie Dressler, so that you have all the letters in one place in case you want to reference them all. And that's a little much to send to everybody, but we'd be happy if you just fill out that page, fax it to us, we'll fax you back the ones from your state. So number one, we defined the issue. Number two was divide and conquer. We took on the 50 state dental boards. We didn't go after the ADA. We marginalized the ADA. Okay, they've got their opinion, we've got ours. So what? You're wearing the hat, you the board of the state of Minnesota or whatever state you're Nebraska, wherever you are. We went to the attorneys general, we went to the governors, we went beyond the boards to bring the boards into a broader range in state government so they couldn't meet in a corner and hide and just zing people for whatever feeling they wanted to because they had to answer to their lawyers. They had to answer to the one that appointed them. We can't force the issue on a governor or attorney general or on anyone, but we can present it. And we did get a lot of responses, and we've got a lot of involvement of the attorneys general. So number one, define the issue. Number two, divide and conquer. Number three, get your allies. Get your allies. Number one is dams. Number one is the consumer groups. I told you all in Houston, right, when we got started on this in the fall of '96, that you needed dams a lot more than they needed you. That's still true. It's more true than ever. You need to support them. You need to help them financially. You need to be with them because they're the people that have turned out in Ohio with Nancy Garrity and state after state when we've gone before the boards. They've brought people there. It isn't the dentists that make an impact. It's hopefully the attorneys and the legislators if they're there like in Colorado, but the consumers. You've got to have them and it works. And the other ally that's so important now and emerging because of some good work of a lot of people here like Bob Jones, who's worked closely to help put this together, is the American Academy of Environmental Medicine. Rick Wilkinson here, Rick Piccolo, Allison of the association, they're dismantling there, but they have really put together. The doctors are so important. The physicians are so important. You've got to work with them. You need physicians that are cooperative, that'll stand up for this issue. It's essential. So go to the allies. It isn't just dentists in this. It's physicians, it's consumers, it's everybody. So those, I think, are three lessons that's worked. Marcia Basquiani and Blanche Gruby suggested I mention this. I do want to mention it, and that is, this is kind of a word on the legal issues that could come up with any dentist, is in your malpractice policy, if you have it, find out if it covers you if you are attacked by the board. Some policies cover it, some don't. It'd be pretty important to know that or to get a policy that does, because the biggest problem you face probably is not from patients, it's probably from that board. Some dentists have found that their policy does cover them when they have an attack from the board. Some, unfortunately, have found out that it does not. We've got a very I will be back in the fall in Colorado, of course. We will start our third year of this project. We will start with a new plan, a new third-year project. I don't know what that is. That's why I hope you all, doctors, you were talking to me, Chet, earlier, will come up with some ideas about what we can make the third year a success. Meanwhile, we need to make this second year a success. We need to make sure that these boards continue to hear. A lot of boards haven't responded at all. We need to ask those boards to respond. Some governors and attorneys general did. The boards need to respond. Some are saying, okay, we're going to be neutral. We're not going to write a rule. That's all right. Mike Ziff tells me that a couple dentists have had cases dismissed in recent weeks where we had appeared before the state boards because the boards recognize that they're going to say they're neutral, they better act neutral. So we're getting people to back off. It's the right thing. But don't walk away. Don't let these boards think we were here and then gone, because the State Dental Association is going to remain there. Get your consumers to keep writing letters. Write letters yourselves. Make sure that the presence is there. We've got to see this 50-state project through. Over the next few months, we're going to try to get answers from other boards. We're going to try to get clarifications from negative answers like New Jersey, but we're going to try to push it. But we only push it not just from Washington with lawyers, but push it from you all in the states and you all with your patients and other consumers. We can see this thing through, and we can make sure that there's a level playing field for mercury-free dentistry. Thank you.
Thank you, Charlie. Is Murray Vimy here? I thought I saw him stick his head in the door back there. Dr. Vimy. We'd love to get him up in the front also. Teresa, are you here? She wants to announce the results of the raffle. And then we'll, as soon as we get finished with this activity, we'll have question and answers here. We will have to vacate by 5:30. However, there is an additional space been provided for us through the lobby, past the elevators, out the back of the hotel, straight down the sidewalk until it ends, and to the left in where we had a meal yesterday. Some of you ate there. There'll be an opportunity for the presenters to go and answer any other questions on a more informal basis over there. Have we got a mic for the folks asking questions? Excellent.
Thank you all for participating in our auction. It's one of the few ways we have to raise money for dams. Your donations and memberships are the other ways. We raise money. As you know, we're a nonprofit organization, and it's all tax deductible. The Jerome Mercury Vapor Analyzer goes to Phil Taylor from EMEX. The free radical therapy seminar admission goes to Dr. Gerald, and I can't read your handwriting, Vermetti? Vermet. The Dentarvac system goes to Dr. Elmira Gadal. And the one of the two motivational frame pictures was bid on and goes to Dr. Blanche Grubing. If those who bid could see me outside, we'll take care of the paperwork and get it all off to you. We can ship it, or you can take it home with you, whichever works best. Thank you very much.
The main question to Dr. Nickel is, what is the time frame for a local anesthetic that we can use?
We're hoping by December. In the meantime, we do have Demerol.
And when you say that, that's for sale to dentists where they can start using it?
That's what I'm hoping for. I don't know because I'm not the federal government. I'm not the federal government, so I don't know what they've done, but I'm hoping by December of this year, 1998, there'll be an alternative.
Dr. Nichols, thanks for your presentation. Could you go over the Hubble technique in the use of Demerol and dosages and exactly where to inject, et cetera? Because we need a technique to take home here.
Yeah, the handout has on it a sheet about Demerol and its usage as a local anesthetic. Those are due to my work, and those are the clinical usages are outlined in that handout. The Hubble technique involves using intravenous Demerol and a barbiturate and maybe some succinylcholine, put the patient to sleep and do the procedure. Adrian Hubble felt that this procedure could be used easily by trained, qualified dentists for dental procedures involving pain, such as initiation of root canals and so forth. I think you'll have to look for alternative techniques, like can I do it with nitrous? Can I use it with a PO narcotic without use of local anesthetic? You're going to have to tailor your anesthesia for the procedure, is what I'm trying to say. And then you may have to modify your procedure so that the pain inflicted on the patient is minimized.
Dr. Nichols, can you document objectively that there was a decreased use of the local anesthetics in those areas that you mentioned, such as Washington, D.C., New York, California, and so forth?
No, you can't document it. All the data on usage of local anesthetics is proprietary to foreign manufacturers, so nobody in the United States has access to that information.
Okay. One of the things that is intriguing to me is that one of the long-term uses of local anesthetics has been doing what is called neurotherapy. And it's a technique of injecting painful areas, which has been very helpful in relieving pain. It is also a technique that has been used in the hands of many in Europe as well as here in this country in the treatment of such things as cancer, and has been very effective in some of those hands as an adjunct. I find it a little difficult to see it being such a dangerous medication, especially in light of some of the other positive effects that it has. Could you speak to that, please?
Well, the local anesthetics are both an angel and a poison. And what we're dealing with is a toxicity that affects a small percentage, but turns out to be a large number of people and a costly problem, cancer. So you're obviously, I would guess that 499 people out of 500 are going to walk away with no ill effect of usage of this drug. But then you're going to have the one that has cancer. So you have to weigh that toxicity in terms of the numbers. And that's why the drug has been beautified since 1905. But in 1910, Professor Brown, who wrote the book about use of procaine, stated in his book in 1910 that procaine was a human poison never to be forgotten. And he went on further to elaborate. And he had actual clinical cases where 6 hours after injection of, say, 3 cc's of procaine for a dental procedure, the patients had come to cardiac arrest. These are cardiotoxic drugs in addition to cancer. And I have not looked at the cardiotoxicity at all. I do know it's there. And I know when we eliminated the injectable local anesthetics in our office, the cardiotoxicities on our scopes disappeared. Totally. All the cardiac arrhythmias, that is ACLS and advanced cardiac life support demanding on the oral surgeon, disappeared, literally. So we have been blessed by not seeing the cardiotoxicity since we stopped using the drug. In regards to pain management, I think that you have to weigh the benefits versus risk, and that was the argument with FDA. Today, that has been replaced, that benefit versus risk criteria. And in September of 1996, a new regulation took over at FDA, where animal studies, biochemistry, metabolism count towards determining the beneficiality to the drug to society. And now our local anesthetics currently qualify as unbeneficial drugs based on that law. So it's no longer benefits versus risk. I think the objective, as I've outlined, I've talked to many people at the federal government, and I've outlined it in writing, is that we professionals do have education, and we have to change our education and our choice and what we do. We do have that. That is a tool.
And Dr. Nicol, I'm from Canada, and it's been rather serendipitous that I've been using Ultracaine since the stuff came out. So it's kind of nice I'm at least doing one thing right. But my question would be, why has that not been made legal here in the States, for one thing? That's my first question. My second question, have you done any comparison of the mortality rate for cancer in Canada versus your comparisons here in the States?
Yeah, the cancer mortality for Canada is greater than the United States. Greater. More of you folks die from cancer than we do down here. Ultracaine in Canada is limited for the general practitioner, essentially in dentistry. Is not used medically. Ultracaine has an issue that the reason it has not come into the United States is because its chemical structure is designed in such a way that it mimics the aniline structure of lidocaine. And for that reason, and you're talking to the person who stopped it, that's why I went to FDA and said, no, we're not letting this one in. And to this point, Ultracaine has not been licensed in the United States. We believe one of the toxicities is paresthesia. There's higher incidence of paresthesia with Ultracaine or Articaine. And basically, I threw a fit and I said, we got to find an alternative. And so FDA agreed with me and Kessler agreed with my concern, and the drug's not in the United States. So at this time, we don't know really what the bizarre ring structure component of that Ultracaine or Articaine is in terms of human cancer rates. What type of role it plays in Canada, I don't know. But we're not letting it in the United States. And I'm the one who pulled the rug out from under it. Okay? So that's where it is now. Now, if the FDA will finish the studies that I asked them to do on Articaine and Ultracaine and prove that the safety is there, then it should come in the United States. I'm not against the drug. I don't want to replace what we have in the United States, the mess we have now, with another drug that'll cause a bigger mess. And that was in my letter in 1993 to FDA. And I think from now on, we need to have a healthcare delivery system that monitors toxicology, where in the past, we turned our heads to it and walked away from toxicology. And I've asked the federal government to place those necessary structures in place so that the toxic side effects of practicing professionally will be eliminated in this country. That's the ultimate goal. Does that include now? Well, toxic compound. I've asked for them to put the institutions into place. I've asked them to collect the human data. I've asked them to find out and correlate it to animal data. And now, today, the FDA law that took place, the regulation that took place in and September of '96 reflects that. So there is something in place now. There wasn't before.
Dr. Nickel, right here. Any animal studies in Germany on the articane as far as carcinogenesis?
Germany's cancer mortality rate is greater than the United States by a factor of 1. And they do use articane or ultracane in Germany, yes.
What about specific animal studies on articane in Germany?
The animal studies, the articane metabolite has not been studied in animals, although the next stage metabolite, the thiophene, has been, and it's totally safe. It may cause some respiratory fibrosis, and that's about it. It could be liver toxic in high enough dose. The stuff I've talked about, these aniline metabolites, I should let you know, also translate to the same structure you used to using in your pharmacy. It's called acetaminophen. Another name for hydroxyaniline is aminophen. So you can guess what acetaminophen metabolizes to in your body, and then decide what it relates to. Is it a risk? Animal studies at NTP are equivocal, but they are there for leukemia, and that was in 1994.
Well, difficult to know where to begin. It's about your interesting talk on neuropathy and yesterday. We're all here just sort of humble dentists, and for those of us who've been involved in this organisation, find our practices changing, to say the least, with the patient presentation. And it was going back to that interesting case of the bicyclist who was affected after the equilibration. Just talking to the colleagues around about, we've had, I suppose, through our dental practice, and I must say we only practice dentistry and not medicine, of course, we've had about, I would say a couple of hundred of these sort of cases come into us. And I'd just like your comments really on how we would treat such people. We have, I always keep in the office 7.5 grams of sodium ascorbate for immediate IV injection for these people as they walk through the door, because this buys us about 2 to 3 hours of time. So when they come in with a paralysis and in wheelchairs, we give them this stage number 1. If the symptoms start to resolve, as they nearly always do, then we sort of suck out blood and send that off for a liver analysis. Then we ask for sort of stool analysis and whatnot, because with the stool analysis, not only do we ask for mercury, but we also like to have some of the fatty acids, butyric acids, etc., to see how the anaerobic bacteria in the gut are doing. Because what we found then is, if we give these people, and I'm not doing medicine, of course, I'm only a humble dentist, we're just doing dentistry. If we then give them, say, 120 grams IV, round about this sort of dose, sometimes more, sometimes less, there's other factors involved, of ascorbate on a daily basis for a week, give them also a bacteria, a gut bacteria that we've had developed in Sweden, which is grown on a rye base, because we found the gut bacteria that you get is grown on a milk base. People react to the proteins, the casein protein in it. And it's a live bacteria as opposed to a powdered bacteria. That if we do this, normally at the end of a week, the people walk and we don't have problems. And when we get the liver results back, these people always have uprated liver enzyme, G6PD, etc., etc. And so we assume this automatically, and we give them alpha lipoic acid. We give them it orally, but we give them IV ampules because it's the only pure stuff. All the rest has colorants and tablets and so on, which they can't react. And we find then at the end of a month that their liver values and stuff have gone down to normal, and then we could go outside of the immediate emergency phase and do a long-term planning. But this is not medical treatment, of course. This is just dental treatment that we're doing. And we're unfortunately not being able to position to charge for this either. But every week, every couple of weeks, we have someone like this come through the door, and the other people who've been in the IAOMT will see them as well. So this is our way we treat these people, because of course we don't. We're only dentists. But this is our way of handling this sort of problem, which I see, and certainly most of the members have been here a long time, we see people like this on a weekly basis walk through the doors, and they don't come to us as the first call. They come to us because we're the last hope they've got. So,
what type of diagnosis do
what type of diagnosis do these people have when they walk through the door?
Yes.
Well, they can have anything from peripheral neuropathy to absolutely no diagnosis at all, where they've had all the lab tests in the book, and they come in with literally 2 A4 folders full of lab tests. And the doctors have told them they're completely healthy, there's nothing wrong with them, but they're completely wiped, and they're just non-functional. And they usually go, these are the acute cases that are going sort of rapidly downhill. That sort of word of mouth has got about, and so they end up with me.
What state do you practice in?
Nord Rhine-Westphalia.
Where?
Nord Rhine-Westphalia in Germany.
Germany. I was hoping you'd practice close to me, so I could see something.
Well, if you want to see the result, if you want to see we have the statistical results, and they're available from the state criminal police, who have all our data at the minute.
Well, just one comment is that the 2 cases I presented yesterday are the only 2 cases I know about where there's been occlusal equilibration followed by neuropathy. And so if you're seeing hundreds of cases, I mean, it's unfortunate that they aren't being looked at more closely. If that's the same experience that you other dentists are experiencing in the United States, or at least closer to where I practice, please communicate with me. I'd love to get involved in evaluating these folks.
Just a question to Boyd. If these aniline compounds get broken down like acetaminophen, won't glutathione help detoxify the compounds within the body?
The aniline compounds he's talking about, glutathione won't do anything to those.
No.
I mean, the aniline compounds are carcinogenic. I don't know the levels that are produced by this. Aniline compounds are carcinogenic. I just don't know the level you get from an injection, like a rate of breakdown and the concentration I don't know that. But I do know that they are carcinogenic, as he says. And glutathione won't take them out.
Well, Dr. Nichols, what are the levels? Add to it.
The serum level, OSHA is still trying to determine now. The serum level is going to be based on the occupational skin level exposure. The skin level exposure is in micrograms per square meter. You're injecting milligrams to the patient. So your factor above OSHA levels are 10 to the 4th to 10 to the 6th. And the OSHA levels are known to produce cancer in humans, which is in micrograms to skin. But blood levels are not known. So you can argue that the blood level, OSHA's blood level is somewhere around 10 to the -8th, and we're around 10 to the -3rd.
And this question is for Dr. Haley. Dr. Haley, I was wondering why estrogen, can you hear me? I was wondering why estrogen is considered helpful in postponing or preventing Alzheimer's. or do you think there's any evidence of that?
I don't think there's any doubt that estrogen, there's evidence that estrogen, is somewhat helpful to the onset, delaying the onset of Alzheimer's disease. I don't think anyone knows how it works. If we did, we'd be after it. But there is data suggesting that that's the case.
Thank you very much.
I'll ask this one just for the general panel. I know in that the German doctor who died from the coma of the dimethylated mercury, do you know what the doctors used to try to neutralize the toxic effects of that? For example, I think the N-acetylcysteine, the medical doctors used for acetaminophen poisoning from the effects that you were talking about in the liver. Do you know what they used in that case, or could anything be used in the future related to this kind of poisoning? And from what Dr. Nichols is telling us about the aniline derivatives that cause the same problem you're seeing in the liver as acetaminophen and from the Tylenol?
Is this the case at Dartmouth with dimethylmercury poisoning? I don't think she was treated. She was?
She was treated, I believe, with PNPS, and she had hair analysis done, and I talked to Gary Myers, who's a neurologist at the University of Rochester, that's done some scanning of her hair to look at mercury levels, and it appears that she had been actually exposed to mercury continuously. It's not a one-time shot. So she may have gone over a certain threshold with this last exposure to dimethylmercury, but her hair levels, you all know you can analyze it from the skull, and come up with a nice profile of hair. She's been using it continuously. It's not a one single time shot of dimethylmercury. It goes very readily to latex, no question about it. I think she wore the double layer of latex gloves and done some experiments, and it would just sit through. It doesn't know. There was another case of a scientist in the 1970s, 71, I believe, Australia, who's died from the same kind of exposure. But people use dimethylmercury actually all the time. So there may be a subset of people that is very sensitive.
And Dr. Nichols, are you aware of the preservatives used in procaine? Some of the neuro doctors are using a preservative-free procaine. Would that make a difference? Or in your studies, was the lidocaine or procaine derivatives used with preservatives or without? Do you know if that's in the literature?
That's not a factor with the aniline. You're dealing with the metabolite from the local anesthetic, so you're dealing with simple chemistry of conversion. That's molar chemistry, which we were taught at one time, and you're dealing with that metabolite. With regards to liver, you mentioned the liver. With acetaminophen, it's absorbed, and the theory behind it is that the liver detoxifies the acetaminophen, the minophen, before it gets into the bloodstream, while the dental procedures bypass the liver detoxification and slams it in the bloodstream. So that's where the problem comes. Back in 1936, Dr. Durham, who was head of DuPont's medical research unit, argued that cancer was determined by blood levels of the carcinogen. And that was the criteria if you were going to get the cancer or not, if you had high blood levels. So you could escape it by having skin exposures minimally. But the blood level is the key. And then the liver is supposed to detoxify it. So that's how the Tylenol manufacturer, or acetaminophen, acetaminophen manufacturers have argued the safety of acetaminophen. We argue against it because they haven't done the studies to tell us how much is getting in the bloodstream.
I had a question for Sandy. Sandy, I'm over here. There we go. In addition to the mercury release with the occlusal equilibration, grinding down the posterior occlusion will cause compression of the spine. In my office, I recently had an individual who had 14 years previously fell through an elevator shaft, 2 stories, landing on a cement slab. He had numerous fractures in the spine, body cast for over a year. We do a special analysis with the cranium. His bite was off the thicknesses of 2 sheets of typing paper. By placing a thin layer of occlusal resin on the right side, he was totally out of pain within 2 days in the neck and 75% of the pain in the back. A lot of neuropathies are coming from loss of vertical. Most people have a loss of vertical to begin with before the occlusal equilibration.
I hope I wasn't saying anything against occlusal equilibration.
No.
I know nothing about it.
No.
But what point of the talk was that that grinding down amalgams can be associated with phenomenal levels of mercury, and you can avoid it. I like your idea of building it up instead of taking it down.
Well, then my point was that it's a double-edged sword there, that you can help somebody out if you remove interferences on the bite, but unfortunately, if you're taking a little bit too much off, you're going to affect the physiology of the spine. My other question was for Dr. Nichols, though, statement. Is there an antioxidant that is effective for the aniline?
It turns out it's not the oxygen issue. That was early on in the work. We thought we could explain the appearance of the free radical oxygen through the chemistries, and it does occur, but it's really the aniline, the carcinogenic compound. That's the reactive compound. We're up a creek.
I'd like to ask Dr. Kuby a question. In your practice, I very much appreciated your speech this morning. I thought there was a lot of wisdom in what you had to say. Do you deal primarily with pain, or is there a broad spectrum of issues that you treat as well? Could you tell, I was aware of the pain issue in particular. Could you give us an idea of what other kinds of disease entities or problem areas you can treat with your approach?
I'm going to speak in English again. No, I said that there were 3 levels of health status: without symptom, with functional symptom, and with organic diseases. And I stressed the point that we can be helped in our diagnosis with some simple tests to test pain, because people, even if they are suffering from a heavy disease, they have pain, and we can have a proof with this test that there is a relation between dental status and general health status, just to prove them that something exists. But in my practice, I used to treat MS or SLA or cardiovascular disease, and I used to do a lot of things. I used to remove amalgams, I used to do chelation, I used to extract teeth, but with this simple test, we can have an help. That's what I wanted to tell you. Okay.
Again to Dr. Nichols, with all of the supplements out there, that work on the chemistry positively, is there anything, or have you looked at anything that might be interceptive, that might take out this carcinogen or convert it or anything like that?
We don't have anything on how to detoxify the aniline from the body. The only thing we have is non-exposure. That's historic and still true today.
Any other questions?
Could I make another comment? Excuse me.
My question is for you.
To follow up, that's what was interesting about finding this data that suddenly showed up in the newspaper. And you can take that for whatever you like. What was interesting in finding the decrease was, for the first time, we had some evidence that if something was out there, the rate would respond and with a decreased occurrence of death in a short period of time. And in terms of toxicology, you'll have an onset curve and then you'll have a decay curve. And we were looking for the rate of decay. And I pushed President Clinton the day before his State of the Union to tell the nation about what causes cancer. And the best thing he could say was, we're going to get rid of cancer by the year 2000. So he knows something. Question is it the same stuff as I know?
My question is about the same subject. If it took 25 years for you to reach the peak and then you have an automatic decay, how do you see then the relationship of a decline in cancer in New York and Washington, D.C. happen so quickly?
It happened because people didn't go to the dentist. We're talking about people who didn't get exposed. And
But
a decline occurred in death rates.
But there were a lot of people who got exposed 25 years ago, so that you're saying that 24 years ago or 23 years ago there was less people going to the dentist?
No, it takes 20 to 25 years for the toxicity to show up in a population. But if you were to withdraw the chemical, immediately you'll have a decay. Will the decay occur a year later, 2 years later, 20 years later? We don't know, but it looks like it's going to occur within a year. So decay rates unrelate to onset, and the onset of a problem individually is different than an onset for a population. So if you look at a population, you got to separate individual experience versus population data. Population data takes 20 to 25 years to show up. Individually, doesn't work that way. It appears to be a toxicity. If you don't get exposed now, if you stop exposure now, in other words, you never went to the dentist and you never went to an MD or a podiatrist and never got any local anesthetic, in all probability you won't come down with cancer. That's what the data now says. Does that make sense to you?
Oh, but that's always made sense to me.
Okay.
Stay away from those guys.
Dr. Nichols, I have a question for you. You talked about paresthesia, how the paresthesia during surgery many times is due to the breakdown of the local anesthetics. Is that correct?
Correct.
And you said that the success rate over a period of time was what? That the paresthesia would go away?
If you change the dosage of the local anesthetic to the neurovascular bundle, eliminated it, your paresthetic incidence would drop.
Okay, what was this? You said that also the paresthesia would come back eventually, didn't you? That if you did nothing.
Oh, what I meant is not that. No, I meant if a person has a paresthesia and I as a surgeon did nothing but observed it, that person's 98% of the time symptoms will return to normal.
And do you have a reference of time and how long that took?
It's usually within a year. It is age-related. It is in the published article, the 1990 article. The data's there, but I can't recall the exact data. But it's usually within a year, 98% of them return to normal.
Is there anything that we could do to help that to progress faster?
No.
It's just time-related then?
Time.
Thank you.
Any more questions? Well, it looks like everybody's sufficiently worn out that it's time to call a halt to our meeting, and we want to thank you for coming. I hope you enjoyed your time here in Raleigh-Durham. Again, there will be an opportunity for you to interact with each other at the location I referred to earlier, out through past the elevator around. Enjoy your evening. Have a safe trip home.